reclaiming the host and making Tapan host.
Okay.
बेटा उन्होंने मुझसे होस्ट है जरा reclaim host करे.
Now you can start. I will started doing recording.
Okay. So very good afternoon, everybody, and as a continuation of the pediatric cardiology for all our colleagues and residents who are interested in learning this pediatric cardiology, we have done the history. We have done cardiac field. We are going to discuss the esteemed panelists with us are Dr. Muneesh Chakravarti and Madam Professor Mala Kumar.
प्लीज म्यूट कर लीजिए, अपने को म्यूट कर लीजिए प्लीज, डिस्टर्बेंस हो रहा है.
Your side.
प्लीज म्यूट कर लीजिए अपने को, बहुत डिस्टर्बेंस हो रहा है. वी कांट बिगिन.
Ma'am, should I continue?
Please do.
Yeah. So understanding the pediatric heart failure is the topic for today. Starting with the definition. The definition initially it was just basically a clinical syndrome caused by low cardiac output, and it's effectively even today is a cardiac output which is failing to.
डॉक्टर राकेश कुमार सिंह, आपके उसमें से बहुत डिस्टर्बेंस आ रहा है. प्लीज म्यूट कर लीजिए अपने को. वी कांट गो अहेड. प्लीज म्यूट कर लीजिए अपने को.
I think something has happened. I don't know what is happening.
मुनीश आप ट्राई करो. आई थिंक अब नहीं हो.
मैं उसको रीशेयर करती हूँ बिकॉज
अच्छा नहीं मूव कर रहा.
हाँ वो उसमें होस्ट चेंज हो गया.
ओ अच्छा.
हाँ बोलिए मैम.
Screen is visible. अनम्यूट कर लो अपने को. मुनीश, unmute yourself.
Yes. Am I audible?
Yes, you are audible and visible.
So heart failure definition for everybody is basically it was initially a clinical syndrome caused by the low cardiac output with later increasing knowledge about the pathophysiology, neurohumoral pathway, molecular pathway, a lot of things are happening and evolution are happening. Now there is a definition that it is a clinical syndrome in patient with the cardiac disease characterized by typical symptom sign associated with a specific circulatory, neurohormonal and the molecular abnormality, and effectively when heart is failed to meet the metabolic demands of the body. So this is the important, and there are many underlying things leading to this condition. When we talk about the cardiac physiology, it is important to know there are three main important things. One is the heart, so the myocardium, the afterload and the preload. All these things has to work in concordant in an effective way to meet the demand of the body. Anything which is like you need a healthy myocardium, You need a defined preload on the heart, you need a defined afterload in the heart. Any imbalance in that, too much of the preload, too much of the afterload, or a weak myocardium will compromise the cardiac output. And this is the heart rate. With addition to that, it is a heart rate and rhythm. Even heart rate is controlled, but rhythm is abnormal, that will compromise the cardiac output. Even heart rate is faster, but it is not of normal type, it will compromise. So very low heart rate, very fast heart rate, or abnormal type of rhythm, anything. So all these four things will define your cardiac output, which is a heart rate into the stroke volume. So stroke volume, preload, afterload, myocardium, ejection fraction basically, and the heart rate. So all have to work. And when we understand the pathophysiology, the etiology, and the management, so everything goes around this cycle. So you need to keep this picture. I will bring it repeatedly into my presentation. Classification, there are many classifications. So students during their UG, PG type, they come to across many type of classification with the cardiac failure. Acute and the chronic heart failure. That is very important, because when patient is suddenly decompensated de novo or underlying chronic cardiac failure, so that will present with the features of the acute compromise, that is the acute cardiac failure. And chronic, obviously chronic disease and patient is living with the cardiac failure, all the symptoms, that is the chronic. So there's no exact duration defined to that. Acute means sudden decompensation related to it. Then comes the high output failure or low output failure. Like when we say patient with the large ventricular septal defect, there is the cardiac output is high, the stroke volume is high, but he is in failure because it is the heart, the body, it is not. Though your stroke volume is high, cardiac output is high, but
Please
patient
mute yourself, other people, please mute yourself.
failure. And when your output is low, like in the dilated cardiomyopathy, poor ejection fraction, then it is a low cardiac output. So it is not very difficult. Ultimately, what is happening? The demand is not met, whatever the things going on here. Then comes the left heart failure. We have two chambers. This is left-sided heart and the right-sided heart and the biventricular heart. So when left heart is mainly diseased, like it is mitral regurgitation, aortic regurgitation, critical AS, critical MS, LV dysfunction, everything will lead to your left heart failure. While on the right side, you have like Epstein anomaly congenital, if we talk about RV cardiomyopathy, there's critical pulmonary stenosis. So any disease of the right heart will lead to right heart failure. Left heart, ultimately, by a passive way, it will call pulmonary venous hypertension, then pressure on the lung, and ultimately right heart failure. So that will be the combined or the biventricular failure. So for a biventricular heart failure, it could be left leading to right heart failure, or both sides are affected simultaneously. Like rheumatic can affect mitral and tricuspid both. So you will have both-sided heart failure in a disease like rheumatic or other systemic illnesses. But practically, you need to understand left heart failure will lead to pulmonary venous congestion. Patient will come with the dyspnea, orthopnea, paroxysmal nocturnal dyspnea. While on the right heart failure, they will come with the features of the neck vein congestion, ascites, liver enlargement, pedal edema. Okay, so this is the way left and right side being clinically presents. Biventricular, you have features of the both-sided cardiac failure. Then comes the systolic heart failure or the diastolic heart failure. Systolic means systolic. Heart is not able to pump what it should. So it is a poor ejection fraction there. While in diastolic failure, heart is not able to take the blood which it should during the diastole. So that is the diastolic heart failure. So there are different causes for these things. For diastolic heart failure, it is restrictive heart disease. For systolic heart failure, there are many types of the cardiomyopathies happening here. Then comes the forward failure and the backward failure. Forward failure, again, heart is not able to pump as it should be effectively. Again, it is a failure of the ventricular to pump. So it is the weak ventricular chamber or the LV dysfunction. Backward failure, like mitral regurgitation. Your heart is pumping effectively, but the significant volume is going back into the lungs and affecting the lungs. So it is not that heart is weak. It is not that the stroke volume is low, but a significant amount is just disproportionate going into the other pathway, or with the VSD or mitral regurgitation, that will lead to your backward failure. So just these are the terms being discussed. The examiner may ask you. So just you should be aware of these terms: acute, chronic, high output, low output, left, right, or biventricular, systolic. So these are the terms we need to just understand. Effectively, cardiac output is being compromised, which is not meeting the demand of the body. So this is the final and if we understand these underlying classification, will work effectively on that and help the child to get better. Another term is for the resident especially, one is classification like NYHA classification on the ROS for the pediatric and the staging of that. These two are different things. Staging means how the disease is progressing in the heart. So this also you need to make a concept about that. Stage 1, when patient is not having any structural or the pathological abnormality of the heart, but they are prone to that. Like there is history of acute rheumatic fever. If the repeat episode happen, the patient may have a bad effect on the heart. Acute rheumatic fever without carditis, okay, that is one etiology, but they are prone for that. So this is stage 1. So we have to give a prophylaxis so that the second episode does not happen. Cardiotoxic drug may affect the heart, so you should be vigilant. Genetically, someone is prone, the family history of dilated cardiomyopathy or hypertrophic cardiomyopathy is there. So the particular person is prone, though his heart is as of now normal, but we keep a watch. Other is like Duchenne muscular dystrophy. Okay, they at the time of diagnosis, their heart may not be affected, but we know that it is going to affect, and that is the main cause of the mortality in patient with the Duchenne muscular dystrophy. So electively we put that is a recommendation them on the ACE inhibitor. So we should know who are prone to go into the cardiac involvement or cardiac failure. So keeping a watch on that, and that is your stage 1. If needed, you may need to start then on medication. That is rheumatic prophylaxis, ACE inhibitor in the Duchenne muscular. So that is, so a watch and a counseling is important. Stage B, heart is getting involved, but patient is asymptomatic. So stage A and stage B both are asymptomatic. In stage A, heart is not involved, but prone to involve. In stage B, heart is involved, but patient is perfectly asymptomatic. Again, we have to keep a watch. We have to counsel the family. You may need drugs like ACE inhibitor, beta blocker, depending on where our heart is going on, or like restrictive VSD. Everything is fine, but LV is getting dilated. You need to close it VSD. ASD require elective closure because heart is involved here, but patient is asymptomatic. So timely correction of these lesions, timely correction doing the intervention for these lesions is important. That is a stage B. Patient is asymptomatic, but there is structural or the functional abnormality of the heart. Stage T patient is symptomatic. So an infant with large VSD in failure, he is symptomatic, you need to correct it. Infant with the LV dysfunction, symptomatic, acute dilated cardiomyopathy or the myocarditis, critical aortic stenosis. So these are the patients you need to diagnose them, you need to intervene. They don't require just follow-up for that particular defect. You just need to correct if correctable lesion. If it is not correctable, a close follow-up with the medication is needed in these patients. Stage D is the advanced heart failure. So this is something very serious stage where heart is bad functionally and structurally. If can be treated, some intervention can be done, you go for the intervention. Otherwise, the follow-up for these patients and very optimization of medical therapy, sometime hospitalization, sometime intervention, ultimately heart transplant. So this is something very serious group. So the staging help you to know where your patient's heart is. Okay. While in case of the functional classification, NYHA is a very simple way of classification. Any patient with the cardiac disease, no restriction. On usual activity, there is some symptom. On more than normal activity symptom and symptoms. So very vague it is. Like for me, symptoms are normal activity is different. For a 5-year-old kid, its symptom is. So it's difficult to put into that bracket what is normal, what is more than normal, what is less than normal. It's very vague, but staging help you to know how to follow these patients, how to categorize your medical and optimize your medication. This is Ross classification, again, same replication of the NYHA classification, but because it is for the kids. So here the feeding difficulty, tachypnea, dyspnea, these things. And the important thing here to know is the growth failure added as in class 3. So growth failure, if there in your patient with the cardiac issues, means he is class 3 symptomatic. But again, the problem is growth failure could be for many, like simple VSD. If it is Down syndrome, VSD is not significant, but because of Down syndrome, they are failure to thrive. So we have to categorize these groups. So this is the difficulty for all these things. Now, there was further modification into the ROS. And this is important. At least the resident should know that something like this exists for the pediatric resident, especially. What they included, the previous one was 0 to 6 years. So beyond 6 years, we were going to use NYHA classification here. It includes all ages, means 0 to 18 years, and they group 5 categories. 3 months up to 3 months, 3 months to 1 year, 1 to 3, 4 to 8, and 9 to. So there are 5 categories, and the symptoms according to age. So total 20 scores are there, and they are classified as class 1, 2, 3, 4. Okay. So just for an example, for 0 to 3 months. So feeding issues, time of feeding, breathing, heart rate, respiratory rate, perfusion. What is important here in the modified Ross classification is lab test, that is NT-proBNP, ejection fraction, and EV. So echo and the lab criteria are added to your the symptoms and the sign, because symptoms and sign is very vague. We can underestimate the sign, the family can underestimate the symptoms. So that's why the lab and the echo criteria added to your usual classification, and that helps to obviously reach a more concrete level that yes, this is cardiac failure, or what level of cardiac
आवाज
failure is okay.
इस होगी ना
So this is a staging which help you to understand the risk factor. You apply the preventive measure, you correct them if possible, and the treatment according to the condition, according to the staging of the family. While the
इससे कनेक्ट हो जाएंगे
classification is basically to just optimize the medication only.
प्लीज
So
म्यूट
these
कर लीजिए, डिस्टरबेंस हो
these
रहा है, अपने को
are
म्यूट कर
different
दीजिए।
things, and the residents, all students need to have an idea that how these things are being applied. Then very important thing is the cardiac failure to thrive. So we all talk about failure to thrive. In cardiac, this is something very serious issue. And if cardiac failure is, if failure to weight gain is there, despite optimizing medication, you have to send the child for the intervention. The causes are many, like intestinal, it's left heart failure, right heart failure again. When there is right heart failure, there has to be intestinal edema. So there is hardly, the patient will always have a feeling of the fullness. There is poor absorption, there is high BMR, there is more losses from GI in the from renal. So there are many factors which leads to the cardiac cachexia in cardiac patients. DCM patient, chronic DCM cardiomyopathy, just come, you can make out from far that the patient is in cardiac failure and what is happening overall with the patient. So this is something very alarming. This 3-month-old baby, birth weight of 3 kg, present weight of 2.5 kg. You just see there is nothing. It is skin and bone only. And after correction of the, it was a large PDA. She did just in next 1.5 months, she was 4 kg. So this is the beauty of optimizing the treatment, timing interventions in these patients. But why there is failure to gain, why child is not taking adequate calories, this we need to understand in cardiac patients. The causes in the pediatric age group, a long list is there for the cardiac failure, and the commonest being the congenital heart defect and the cardiomyopathy at birth, at first week. So different cardiac defects, rheumatic is there, myocarditis is there. So these things, the group is there in your books. Arrhythmia can happen at any age. So congenital cardiac defect, rhythm issues, cardiomyopathy, rheumatic heart disease, these are the main things leading to cardiac failure. Now, any of the systemic disease like your renal will affect the heart, your liver will affect the heart, any connective tissue disorder will affect the heart. So anything which is going in the body in systemic issues other than the primarily cardiac issues may lead to cardiac failure. So you should be vigilant about the heart in patients with the chronic systemic disease, and obviously when there is underlying congenital issues or the acquired bacterial endocarditis, diphtheria. So many things are there which can lead to the cardiac compromise in patients. What should be our diagnostic approach? Obviously, history and examination is very important. So this is we are all reading from our pediatric or MBBS time. So detailed history, what mothers tell you, how mother is coming, what she is speaking, you need to listen to her. Her every word should be taken carefully, listened carefully and taken into account. When problem started, so acute heart failure, the chronic heart failure, what are the precipitating factors, whether it is fever, or how it is progressing, things are getting with time, better with time or deteriorating, what medicine child was taking, is there any family history, on examination, everything to be looked, whether there is sign of CHF there, or if this is control on medication or not control, anemia, cyanosis, how the pulse are, pulse volume. I feel feeling the pulse is so important. So when you are talking to the family, or your fingers should be at the radial of the child. You need to feel the pulse, whether it is of hypertensive or normal volume or feeble pulses. Same time checking the dorsal SPD. So this is very minimal thing you can do when you are talking to the family. That will tell you what is how the heart is, whether child is febrile, how the pulse volume is. it's warm or cold. So many information you will get from just feeling the pulse, and family feel very comfortable when you touch that patient, the child. So you everything you will get from that system. The thing is, majority of time, cardiac failure is treated as pneumonia. So our main indication of admission for the, which I do echo, so they come with the diagnosis of pneumonia. I think it is very commonly, whatever the underlying disease, even arrhythmia, they are admitted first as a first working diagnosis is pneumonia. Then the pediatrician come to know that cardiomegaly or tachycardia, then they refer us to the for the echocardiography. So the first admitting diagnosis in these patients is pneumonia. You need to suspect cardiac failure when there is disproportionate increase in the liver size, pulses are not good, tachycardia is unduly there, cardiomegaly on chest X-ray, there is gallop rhythm, there is murmur. So anything if it is there, you need to suspect. It could be primarily cardiac or cardiac precipitated by the viral infection or chest infection. So any combination or isolation could be there, but cardiac should come into your differential diagnosis when you are managing these kids in this way. Diagnostic approach after history examination, ECG is important. ECG is very underutilized investigation in pediatric practice. I think we should do more of the ECGs. Then chest X-ray very commonly being done. And obviously we need to read from cardiac point of view. So you may get cardiomegaly, you may not. But pulmonary venous hypertension in sick patient, you also look carefully. Dilated pulmonary artery, pleural effusion is there. Pericardial effusion, you can just look, costophrenic angle is obliterated. Just so this suspicion can come by echo, by your chest X-ray only. Lab test, basic investigations plus vitamin D, I feel is very important. And if suspected inborn metabolism should be worked up in these patients. So basic investigations are important because anemia will compromise the cardiac failure. Liver may get compromised because of the cardiac. Renal may get compromised because of the cardiac issues. Electrolytes are important because our drugs will act through liver, renal, and work on the electrolytes. So these everything are important for us. Obviously, blood sugar sick patient is important. So these are the very basic thing to be done. Advanced investigation can be done if needed. Echo is must and has a very crucial, tell you everything. So whether heart is structurally abnormal, or there is pericardial effusion, or there valve issue, or there is pulmonary hypertension, chamber dilatation, any mass in the heart, any thrombus in the heart. So the list is huge, which you get by the echocardiography in these patients. So this is an echo of a 25 days old baby in CHF, and he came with a diagnosis of VSD only. So you look, it is such a huge VSD here. Heart is hardly contracting, so you expect him to be, but VSD usually don't have ventricular dysfunction. If there is ventricular dysfunction, I need to look for the other things also. So there was a critical coarctation of aorta. So VSD doesn't explain the cardiac dysfunction in this patient. There is coarctation. VSD you can initially stabilize by medication, but when coarctation of aorta is there, obviously the medication will not help this child. We have to go for the early intervention, balloon dilatation followed by surgery, or surgery in one go with coarctation and the VSD closer. So these are the patients, the echo will tell you what is happening. And in these patients, your X-ray show cardiomegaly and the pulses feeble, femoral pulse will be feeble. So the clue is there even without echocardiography with you. In that condition, feeble pulses, you think for the coarctation, underlined whether it is ASD, VSD, or whatever it is, the child need to be intervened early for the coarctation of aorta. In selective patient, after echocardiography, we may ask, this is our part, what I need extra, cardiac cath, cardiac MRI, CT, angiomyography. This is the advanced investigation, but up to that, history examination, basic lab test, and ECG, X-ray, echocardiography to be done in all patients with the cardiac failure. Therapeutic approach. The first thing is control the symptom. The family wants the child should be stable. So symptoms are for us and for the family, for everybody, control of the system should be our priority and has to be our priority. Then after stabilizing, we need to identify the cause and we correct the cause, eliminate the precipitating cause like anemia or the fever, and then delay or stop progression of the disease. So these are the four things needed in every patient. Whatever the cardiac issue is there, we have to work on these things. Again, the diagram is there. So your myocardium healthy, your preload, your afterload. So if there is myocard, too much of heart is a very strong organ. It used to work so fast, even in such a sick condition, it supports our body. But too much of load, like too much of preload on the heart, like in form of the severe anemia. If we non-cardiac thing, we think of the thyrotoxicosis, or if there is severe MR, severe AR, VSD, any significant cardiac lesion will lead to too much of preload on the heart, and your healthy myocardium obviously up to a limit will support you, and then it start failing. If for some reason the myocardium fails, so it could be cardiomyopathy, or because of preload, too much of preload for long, ultimately will lead to the myocardium will become sick. So that will also compromise that. And too much of afterload, like your hypertension, like critical aortic stenosis, like coarctation of aorta, anything in the outlet resistance is increasing, ultimately the cardiac output, your stroke volume will compromise, and patient will go into the cardiac failure. Now, the patient is going into the cardiac failure, the body has to act. So body, our compensatory mechanisms come into, start playing their smart role. And the pathways are sympathetic pathway, that is the baroreceptor stimulation, which leads to activation of sympathetic nervous system. Sympathetic nervous system now, because heart is compromising, stroke volume and heart rate are not providing effective cardiac output. So heart rate will increase, cardiac contractility will increase, afterload will increase to maintain a particular mean blood pressure. And ultimately, what is happening? This will lead to myocardial toxicity, and in long term, obviously, it is going to damage. On the other side, reduced renal perfusion will lead to activation of renin-angiotensin system, and we all reading this from our MBBS time. Renin-angiotensin will lead to vasoconstriction, increasing afterload. Again, it is trying to maintain the blood pressure, and sodium water retention to increase the preload. So everything is trying to maintain the preload and maintain blood pressure so that the cardiac output so-called being maintained. But ultimately, everything leading to the myocardial apoptosis, fibrosis, toxicity, and myocardial dysfunction. So things which are going to help, too much of help will going to make damage to the things. Something good is also happening here, that is release of the peptides. So peptides, beta natriuretic peptides will lead to diuresis and the vasodilatation. So in this toxic atmosphere, that is helping us and the supporting the cardiac failure, the system which is going on. So these are the three things: SAS, renin-angiotensin system, and the ANP-BNP plus ADH endothelin are also coming into playing their roles. So these are the things. Some are helping, some are deteriorating. But the first aim of all these pathways were to help our body to fight with the acute decompensated stage. Now, where we need to work. So this is the pathway happening, and we need to work there only. So again, we need to reduce preload, means we have to correct the heart issues. We need to reduce afterload. We need to do something for the myocardial strengthening, if we can do, and neutralize the compensatory mechanism with the negative effect, plus support the compensatory mechanism with the positive. So sympathetic, we need to neutralize aldosterone pathway. We need to neutralize. We need to support the BNP pathway. Okay, so these are we have to work on. Sympathetic, when beta blocker, we need to work. We have to give the ACE inhibitor or ARBs for the angiotensin pathway, and we have to give the drugs to support the BNP and ANP. So this is looks very simple, and very simple we have to work on these hearts to optimize these kids. So management, the initial rule is simple. You need to stabilize, and this is in all patients except in the critical newborn with the drug-dependent circulation, where you have to do the intervention depending on what the issue is there. So it is critical AS, PS, pulmonary atresia. You just need to do either balloon dilatation or stenting or the surgery. So that is the surgical pathway. But beyond that, the patients, the first is control of the symptom. Propped up nursing, I always tell my resident to make the child in a propped up position. That will help, because mother is coming with the child, they are keeping on the shoulder. So that is the best position mother and child know to keep the baby, because child is cardiac failure. So this position we need to maintain. So 45-50 degree propped up is the thing which we need in all kids with the cardiac failure. Coming the diet, high caloric feed, because the absorption is not great, demand is too much. So caloric density to be increased, protein we need, nutrition supplementation, especially iron supplementation, vitamin D and calcium is important for cardiac failure patients. Reduction in salt, there is nothing like salt-free diet. Okay, child will not take. We can't advise salt-free diet or raw food only. So just the normal feed what child is used to, but when the edema and the fluid retention is too much, especially in the older, you may advise reduction in the salt intake. Obviously, adding the extra salt is not recommended. Sauce, achar, these things have very high salt intake. Papad, so these type of thing we need to stop. Fluid restriction, we can't keep the baby dehydrated. So baby has to be hydrated. Adequate hydration is important. Dehydration will further compromise our organ. The pathway will become active again. So you can't dehydrate the patient. Restriction is only when child is unresponsive to diuretic therapy. Otherwise, just making a U hydration is required for all cardiac patients also, because demands is there, the insensible loss is also there. If you restrict too much of fluid, the internal pathway will further come into play and create more toxic atmosphere inside the body. The drugs, what we'll have after load reduction, so we have to work on that pathway. So ACE inhibitor, you all know, because angiotensin pathway we have to work. So ACE inhibitor are there, ARBs are there. If patient is sick in ICU, Milrinone you can start. You can start SNP, because if child is hypertensive, and recombinant BNP. This is the drug will come into every class. Preload reductions, diuretics you need, and the recombinant BNP. Sympathetic inhibition, beta blocker not to given in a sick patient admitted in ICU. That is important thing to be underlined. So when patient is so-called stable, he has come out of, like in ICU, you need the inotropic support. Inotropic support, everything is pro-sympathomimetic. And here, giving the beta blocker is just nothing. So, and you cannot give, otherwise your patient will crash. So that is not the time. It has to be given in the OPD basis and in a long-term follow-up. Then recombinant BNP and digoxin. Then cardiac remodeling. So the lower pathway, lower part of that algorithm issue, there was cardiac toxicity ultimately. So every drug, your beta blocker, your ARBs, your NE, everything is helping the myocardium to remodeling. So these are the drug indicated for that. And for inotropy, inotropes in very selective cases are needed. And the digoxin is one of the oral inotrope available. Evidence-based efficacy is there with the diuretics, digitalis, ACE inhibitor, beta blocker, and now with the evidence-based efficacy is there. For the digoxin, it was the very important drug used. Means every CHA patient was having digoxin as a prescription. Then there was a lot of controversy. Now again, articles are coming in favor of the digoxin. What I feel is digoxin, where I use, where there's ventricular dysfunction, where is tachycardia beyond, like out of proportion tachycardia is there. So there your digoxin I prefer in these patients. In shunt lesion, obviously when function is hypercontractile, you don't need digoxin. There is no definite role of the digoxin. For the adult, there is a guideline-directed medical therapy, and these are the 4 drugs: diuretic, ARNI, beta blocker, and SGLT21. This is anti-diabetic drug, the 4th one, and it is not used as a therapy in pediatric. Just tried in few patients, and patient tolerated. Up to that only we have it tried in around 35-40 patients. So these 3 drugs, diuretic, ARNI, beta blocker, are for the adult, proven. These 4 things they give in all their patients. For us also almost same. In place of SGLT2, we have the ARNI is there, beta blocker is there, ACE inhibitor is there, diuretic. So these 4 drugs we do use in our patients. Diuretics, how important and how long it should be given, because diuretics has its own side effects. In sick patient is volume loaded. You have to decongest the patient. So patient is in failure, swollen. Furosemide is a very important drug, and just 1 dose of Lasix will help your patient in ICU. And slowly you just from IV you come to oral, and then gradually come to the minimum dose which is needed to maintain the euvolumic stays. We need not to keep the child dehydrated. Just hydration stays is important. So start initially, I go in sick patient with the infusion, because boluses causes some more of fluctuation of the hemodynamics. But a maintenance dose infusion help these patients. Then we come to bolus, then we come to oral, and that's just once daily dose is sufficient for these patients. Spironolactone is very important. One is it helps in maintaining the potassium, because furosemide or torsemide, these are the potassium losing drug. So you need to have a potassium sparing drug. So spironolactone work on that. Plus it it documented myocardial fibrillation catapult. It helped in that. So myocardial toxicity which has happened there, it helped in reverting that. So aldosterone, spironolactone is a very important drug in cardiac failure patients. Electrolyte imbalance, and both we are giving, so we have to keep a watch on that. Sodium potassium level, we should keep a watch. ACE inhibitors, afterload reducing drug. And as per the recommendation heart failure guideline, ACE inhibitor should be used in all patients with heart failure, obviously not in the obstructive lesion. So ACE inhibitors are not for the obstructive lesions. For otherwise, whether it is systolic ventricular dysfunction or there is volume overload, this is the drug important and should be used in these patients. In pediatric, we have captopril and enalapril. Adults have a long list and they use many drugs from the ACE inhibitor point of view, but we have our main basket with the captopril and the enalapril. I use enalapril in patients, and we start with the test dose and then start with low dose and go to the higher dose, what is recommended. Angiotensin receptor blocker, these are small list is there. The list is very long, but this is being used in the pediatric age group. The advantage is less cough than ACE inhibitor. ACE inhibitor, one of the side effects is a very chronic cough in this patient, is around happen in 10-15% of the patients. But angiotensin receptor blocker, that cough incidence is lesser, so it is being preferred over the ACE inhibitor. We can prefer over that. Then digoxin. Digoxin is a positive oral inotrope. Their efficacy in favor of, their evidence in favor of its efficacy. It has sympatholytic property. It controls the heart rate. So these are the things where digoxin is helping us. And this is an article which shows that combined inotrope in bradycardic action is unique for the digoxin in compared to other sympathomimetic inotropes. So too much of tachycardia, ventricular dysfunction, digoxin I add to my patient with a cardiac failure. Beta blockers, as I told you, not in sick patients. And what it is helping, in pediatric, in adult it is being used. It is a very recommended guideline-based therapy. In pediatric, yes, studies are in favor of that, and we do use in our cardiac patients, and it really helps in these patients. So the VSD patient, they're waiting for surgery. So the different, like though it's a simple structural cardiac defect, but because of many reasons, they keep on waiting that they are not getting in the government hospital or finance issues there. So these patients, we have to buy time. So medical stabilization important. Diuretic will further cause the tachycardia. So minimal dose of diuretic, touch of the beta blocker, help these patients to buy time when they're waiting for the intervention. This is a very beautiful drug to be used in the cardiac failure. And again, in pediatric patients, we always start with a low dose and then progressive titration to the higher dose is recommended. Inotropes, where it should be used. Very limited use. When patient is in shock, you need to maintain a blood pressure. Like sick cardiac patient, there is too much release of the sympathomimetic. Everything is in action. So all receptors are already saturated. You don't have more to give to put over tap, adding your dopamine, dopamine, adrenaline, non-adrenaline, everything is going to work on those limited alpha beta receptor only. So how they will help? It's just needed when patient is sick. The mean blood pressure is not maintained. In that condition, you have to push positive inotrope, adrenaline or noradrenaline, or vasopressin. Vasopressin is the benefit with that, it does not cause tachycardia. So if you need only pressure, vasopressin is a better drug. Noradrenaline causes lesser tachycardia, so I prefer noradrenaline also. Adrenaline will cause tachycardia, so you can select as a physician which drug I want, but we need to know what are the side effects of these drugs, where it can, like patient is a chronic beta blocker patient, chronic cardiac failure patient. Adding these drugs is not going to help you because receptors are already blocked. So in that condition, if you need drug, you need levosimendan, you need milrinone. These sympathomimetic drugs are not going to help your patients when he is already on chronic beta blocker drug. So what is happening? Your kidney, how liver is there, depend on that, you need to select your inotropes, and very short course, 1 day or 2 days. You just need not to put on four inotropes simultaneously and just sitting 20 microgram of the dopamine, dobutamine, too much of adrenaline. All 4 drugs going together not going to help you. You have to have either 1 or 2. 1 positive, 1 to maintain the peripheral perfusion. These are combination is maximum needed for your sick patient, and time is very short if you are working on a correct pathway, correcting the underlying things. So these are the inotropes: sympathetic, phosphodiesterase inhibitor, calcium channel sensitizer, and the vasodilator. Vasodilator basically when it is hypertensive, refractory heart failure, ACE inhibitor or the beta blocker. And like drugs, hypotension, noradrenaline. So this is the list important. When patient is beta blocker, then these are the drugs. And when patient is liver issues there, dobutamine and levosimendan, milrinone is not indicated when their liver is the issue. In sepsis, so there is a drugs inotrope selected according to the underlying condition also. Like pulmonary arterial hypertension leading to right heart failure. What you need is it's a levosimendan milrinone because you need to relax the right side of the pulmonary vasculature. You need to support the right heart. So your drugs you can select depending what the underlying things, and you get time. Initially, you can start a combination, but then when reports come, you can just optimize your medication or change your medications. Try to wean once patient is okay, peripheral perfusion is maintained, lactate is okay, urine output is good. Try to wean from the inotropes because now and try to shift to the oral medication, which obviously going to be our long-term issues in these patients. Then medical stabilization, eliminate the cause. This is important. So structurally CSD, RSD, endocarditis, metabolic abnormality, arrhythmias, inflammation, immune, IVIG, whatever you need to define the, you need to identify the cause. So you have 24 hours to work and just try to remove those, the culprit. So this is 2 weeks old baby with cardiac failure shifted from the NICU, and this is a critical coarctation of aorta. Obviously, we have to do the intervention. There is no point in buying time this patient. The grown up with the hypertension, at 22 years of age, he was diagnosed to have hypertension first time, and it was coarctation. So much late diagnosis of these lesions is not uncommon for us to see, but we need to treat these lesions. This child, the last week I did severe 1 year old, and he was at 1 month of age diagnosed to have pulmonary stenosis, critical PS. Now this critical PS, the intervention could not be done because of whatever reason. Now he came with a saturation of 58. Look, critical PS is an acyanotic heart disease. Pulmonary stenosis in isolation is an acyanotic heart disease. But when it persists, it will lead to right heart failure, will lead to PFO, right to left shunting, and the saturation is so low, 58%. Sick child, and heart rate so low heart rate because there was sinus node dysfunction because of his chronically stressed right atrium. Then the balloon dilatation was done. And look, the next day, this is the saturation. In cath lab, it was 98. Next day, this was 93. So this is the way they behave so beautifully. Heart will take time to recover, but you need to open the blocked pathway to help these cases. This is a girl, 5-year-old girl. And this, she was diagnosed to have PD at 1 month of age. And for some reasons, she was being not followed up actually. And now she came with a cardiac failure. Heart is so bad. Huge PDA for 5 years. This is 14 millimeter, then underwent device closure. We did it just 3 days ago. So these are the patients just roaming around here and there. Reasons are many, but you just correct them on time, they do good. Now this girl, now PA pressure are 50% of systemic. I started her on pulmonary vasodilator. So unnecessarily a simple lesion is being, I had to keep a close watch how her lung behave. Now after closure, it was subsystemic. Pericardial effusion could come to your ICU with so-called cardiac failure. Like all residents need to understand, cardiac failure, cardiomegaly on chest X-ray doesn't mean you need diuretic. Okay, that is the beauty of the bedside echocardiography. You find the pericardial effusion because in this condition, your heart is already, if you look at this heart, the heart is so compressed, there is hardly any volume in the heart. If you give Lasix, just your patient will compromise. So Lasix or diuretic should be used very carefully depending on what is the underlying indication. So with large pericardial effusion, failure as a cause of leading to cardiac failure, Lasix is not indicated. It will compromise your underlying whatever the body is trying to balance, it will just disturb that system. Then arrhythmias, obviously it is SVT, you need to correct. If it is severe bradycardia, you need to go for the pacemaker. So you need to correct the rhythm also because your cardiac output is heart rate and stroke volume. Heart rate also need to keep a watch. This patient, look at the heart. Ejection fraction 20%. Hardly it is contracting. And what was the culprit is? Calcium, parathyroid hormone, this much. This was on admission blood gas, PS 7.1, lactate 9, 19, calcium ionized 0.5, and this was serum vitamin. So look, if you define, the first thing is you define the underlying issue, you will just, the results are excellent. And look, this heart after 6 weeks of the treatment, and it just in 2-3 weeks, the heart become like this. Vitamin D is a very serious issue, and we need to look on these electrolytes and vitamin D in our all patients with the cardiac failure, especially with the so-called dilated cardiomyopathy. This child, when I did echo, a very sick condition he brought to us, ECG was showing long QTC syndrome, long QTC. So long QTC, I could know that I'm going to find most likely it's a vitamin D calcium deficiency. So on ECG tell you what you are going. So lab report may wait, but ECG will tell you that what you are probably going to deal. So every investigation helps you. So take help of whatever available with your side. I think all ICUs should have ECG and the ABG machine there. So these are the drugs and the correction of the things. Then comes the antiplatelet and anticoagulant. So cardiac failure, these are the also important part. Antiplatelet, ecosprin we do use when there is ventricular dysfunction, severe ventricular dysfunction, non-compaction of ventricle. This is the thing we defined by the echocardiography. The myocardium is unhealthy, apoptosis is there. So in these conditions, they're very prone to form the thrombus formation and arrhythmia. So we keep them on ecosprin. And the Kawasaki disease, you all know that should be on ecosprin till coronaries get normalized. So this anticoagulant, when coronary are huge, more than 10 Z score, there is history of CVA or fresh LV clot or any clot inside the heart, you need to put them on anticoagulant. Duration depend what is the underlying diseases. So this very sick heart, hardly it is contracting. You see there is a clot is sitting there, soft clot. This was a case of dilated cardiomyopathy, and we had to heparinize him, and he was on warfarin. Then ultimately heart recovered. We did stopped everything. So this is the importance of timely diagnosis. Otherwise, if you don't keep focus on this, this will embolize, go to cerebral circulation or anywhere, just close the system. It can go to the coronary also. So you just not have time to save these kids. Good echo is very important. It's not only avalate dysfunction, it's not only the structural anomaly. We have to search for the clot. Sometimes it is just laminated clot. So I have to search clot in all patients when ventricular dysfunction is there. New therapies, we have new drugs. Evaporatin is there, early, which I discussed there. That is the drug, means combination of naproxen, means this is a pro-BNP, anti-pro-BNP and ARB combination. So now the recommendation is use early in where we were using NVAS, ACE inhibitor, that is being replaced by ERNI. We need to stop NVAS before starting ERNI. We need to keep a watch on the renal function when we are giving these drugs, whether it is ACE inhibitor or the ERNI. So these are the new drugs being used, and results are showing that it's helping these patients. The mortality, all-cause mortality is definitely better, improved when we are giving early to the patients with the ventricular dysfunction, dilated cardiomyopathy. And 2019 panorama trial that allowed, initially it was used for the adult only. Now more than 1 year of age, it is being recommended. Dose regime is there. We can start those patients. So you can leave this to your pediatric cardiologist when to add which drug in these patients. So involvement of the pediatric cardiologist is very important when we are dealing with the cardiac failure, obviously. Intervention therapy, ICD, when there is severe ventricular dysfunction, there is risk of VT and sudden cardiac death. So ICD is recommended. These are for the adult. In pediatric also, long QTC syndrome, we put them on ICD. Resynchronization therapy, ventricular assist device, heart transplant. So these are the things for the advanced cardiac care are there. Now prevention. So prevention is very important. We talk about the treatment, but first thing is the prevention. If things does not happen, it is great. That is best for everything. So timely correction of the structural anomaly. You need to push towards the timely correction. And a very good article on the congenital heart disease, our 2019, it is in IAP only. All of our pediatrician colleagues should go through that, and at least your prescription paper should have if a VSD of 3 months, large ventricoseptal defect, that correction is needed by within 6 months of age. That I think prescription should carry, because when patient come to us, we send the patient back to the pediatrician, guiding them, but ultimately they will listen to their primary physician. So it is we all of us work together to help these kids, because these are the correctable lesion. This is the thing to give a normal life to these patients with a correctable lesion. Hypertension is another cause with whether it is primary hypertension in pediatric is most common is the renal hypertension. Early timely diagnosis and treatment is indicated. Arrhythmia should be suspected and treated. Nutrition is very important. Nutrition issue like berry, calcium, vitamin D, iron that will lead to cardiac compromise, cardiac failure. Patient on chemotherapy, radiotherapy, cardiac, we should be vigilant, and elective drugs are recommended for them also. Diphtheria is very bad disease. We do still see diphtheria patient with cardiomyopathy, and that is a preventable thing. Cardiomyopathy, there are many causes of cardiomyopathy. Primary cardiomyopathy, secondary related to systemic disease, everything. We need to be vigilant and start timely treatment and long-term timely follow for these patients. Any systemic disease like Duchenne muscular dystrophy, renal, liver, endocrine, connective tissue disorder, cardiac involvement is known, and keeping a regular watch, keeping the involvement of pediatric cardiologists is important for them because the damage when it is done is a permanent. So better to act proactively in these patients so that we can, if we can prevent it is best. If it is there, we can slow the disease and we can make their quality of life better. So this is 8-year child come to refer to me for echocardiography because of severe cardiomegaly on chest X-ray. And this was the heart, hardly moving. And what was the reason is this was the hypertension. So for this child, this was the blood pressure. You can see it is 8 year. He is 8 year. So it is not a one-day disease. Obviously, when heart fails, it takes years. So things started long ago. His kidney issue, it was a patient of the kidney disease. So then from chest X-ray to echo, then hypertension, and then acting on the kidney. So this is just reverse cycle which is going on. Obviously, the blood pressure, if we check routinely on our OPD basis, we can prevent this something very serious thing happening in these our pediatric patient, in our whatever patients. For everybody, blood pressure should be checked. This is a child with diphtheria referred for the cardiac evaluation. So this is the ECG. You all should understand this ECG. Very low voltage. Hardly I see voltages in the actually limb leads. So hard because there is no mass in the myocardium. It is such a poorly contracted myocardium with the thrombus sitting there. So these are the very sad thing happening, which we can obviously prevent and better not to happen these things. So again, coming to my same diagram, optimizing your myocardium, optimizing your preload, optimizing your afterload is important to help these patients with the cardiac failure. So any child with CHF, you need a detailed evaluation by pediatric cardiologist, good ECG, echo, everything. Just basic investigation needed. Optimal medication is important. You need to correct the things on time. You need to, if it is cardiomyopathy, because these are the two things. One is structural issues, whether it's congenital or acquired, you correct them. And the cardiomyopathy, primary or secondary. So these things we need to drug management is very important in the cardiomyopathy patients, and studies are showing they are slowing the progression of disease. In many of the patient myocarditis, heart become very normal, perfectly normal, but smartly using the drug is very important thing in these patients. Thank you.
Wonderful. And so well covered, well within time. And I loved your gadha to nahi kehna chahiye, the donkey. That picture says it all. Preload, afterload, and the donkey itself. Wonderful. And I learned something new, which I learned was this RNA that you're talking about. इसके बारे में और पढ़ना पड़ेगा to really get into it.
It's a very good drug actually. Adults are using it, and we always learn from adult only, whether our cath hardware or our medicine, everything first they use, and then I'm comfortable because my husband is adult cardiologist, so I get the opportunity to learn from him in cath lab everywhere. And their drug management, and because their patients are different, it is ischemic heart disease, chronic cardiomyopathies they deal with. Our lesions, mainly correctable lesions, so we can correct on time, we make them free of the disease. But in these cardiomyopathies, it's their work is very good. And I do use, and Manisha will agree that the child becomes so stable, and you feel like that these hypocalcemic patients, if you miss that calcium check, you just, and this patient, when he was severely acidotic, his calcium ionized 0.6. When we corrected acidosis, it came to 0.5. 24 hours it required to calcium to come to 0.8. This is something, and I think all our residents should understand this. Sick child will come with the acidosis, metabolic acidosis. And low iron, calcium may not be very low, because in acidotic atmosphere, the calcium will be more ionized. So you may misunderstand that calcium. So which 0.6 I'm showing, it must be practically 0.1, because after acidotic correction, it became 0.5 and then came to 0.8, 0.9. So whenever we correct acidosis, we should be very vigilant about the calcium. When you are giving soda bicarb, your calcium is very important, because that will something disturb the calcium hemodynamics, hemostasis. So just knowing basic calcium, basic is a very basic thing. We just need to revise our MBBS time. We just don't need many smart things actually. Just remain there, and that is wonderful actually. Nothing is missing there.
Yes, Arnie, actually, during the trial, because when this pediatric trial was there, I was the only cardiologist from India to be in the part of that Novartis Panorama trial, which was published in Circulation. I was lucky because I was in Apollo that time. And in that, we had 8 patients in that trial we gave placebo to some children and that Vameda, that drug to some children, and it was seen actually there was morbidity benefit in DCM patients, not much of mortality benefit that trial showed, but yes, but the cost factor is a limiting factor in our country. But in our children, the dose is so less that they are managing with the cost, and definitely if we can manage. But yeah, definitely in our DCM patients, at least 50% of them, they do improve with the management. If we are aggressive with our management and the diagnosis within 3 months, we also give them IVIG and all the other management together. If the parents are willing, 50% of them do improve. So we should not ऐसा नहीं है जो हम छोड़ दे उसको, मतलब if they should be destined to leave the treatment and DCM कुछ ना करे, ऐसा नहीं होना चाहिए. Some of them, like as Muneesh told, severe anemia, we have to treat them. Calcium, we have to treat them. Thyroid problem, we have to treat them. We have to treat the treatable causes. Vitamin B12 deficiency, beriberi, all these treatable causes should be tackled. Thyrotoxicosis, maybe they are very rare, but some of them have the treatable causes. So we have to treat all these causes.
And
Very
hypotoxic.
excellent talk, Muneesh. There are some questions in the chat box, Muneesh.
Ma'am,
I think you should.
may I have one humble submission?
Yes.
हाँ, थैंक यू डॉक्टर मुनेश. मतलब मैंने तो कभी सुना नहीं इतना अच्छा पीडियाट्रिक कार्डियोलॉजी. Thank you very much. I am all well. I am having goosebumps. One humble submission regarding Ernie is also. See, if you are using Ernie, it's a very good drug, but the issue is we have to monitor renal functions very carefully, because most of these patients are also using diuretics.
Yeah.
And sometimes the combination of diuretic as well as Ernie may be disastrous for these patients. So Dr. Munesh will be agreeing with me. And blood pressure. 2 things are very, very important to monitor if you are using Ernie. This is one submission.
Very, very small dose, very watchful initially, especially. And when like diuretic, what I feel in my DCM patients, very early you are able to wean them from the diuretic, because when you are working on this afterload things, initial phase you need diuretic, ultimately they are alternate day or hardly any diuretic on. Initially you need a lot of diuretic. Now, because understanding is so, you need to them volumic, obviously, otherwise, as you said, kidney will compromise. So kidney toxic drugs, so 2 kidney toxic drugs, Ernie is supporting myocardium plus afterload.
And that too in a sick child. Initially, we have to be very careful. This is for residents only. Otherwise, we are learning a lot from you. Secondly, being a pediatric endocrinologist, as Dr. Muneesh said, we are seeing a lot of parathyroid hormone issue and thyrotoxicosis. They are not very uncommon. They are commonly seen. And the beautiful thing about these things is that once you detect them, the child becomes absolutely curable.
Yes.
So, PTH and, FT4 and TSH, all residents, they should do it routinely. Thirdly, again, for these beginners or our pediatric residents, try to use blood pressure with the appropriate amount of size of cuff as a habit or in your daily routinely OPD. Believe me, you pick up the cases. To pick up the cases, madam will be agreeing with me. If you are measuring blood pressure and always use algorithm, age specific algorithm which is given in the back of the Nelson, it should be handy with your table all the time. Because 100 by 50 might be normal for 18-year-old, but not might be like 50th centile. Ma'am, are you agree with me?
Yes, yes.
Using age
Definitely.
appropriate algorithm and the appropriate cuff size is very, very important. It's a very trivial thing, but very important.
I think blood pressure and saturation actually.
Compulsory.
Yeah, we do see, means pediatric prescription should not be without having these
Without.
heart rate, saturation, and blood pressure. Weight and height, obviously, you all are checking. But these are very important number and certain, when we talk about staging, so second stage, you will only pick up if you are checking these numbers.
And ma'am, like that's also not like just like we are writing height -2 DHD plus 2 DHD. So like that also blood pressure we should also write with the
Yes.
algorithm what SDS is this blood pressure for that age and sex.
And
So
then working table is there because
yes,
heart,
because measurement is one thing and interpretation of that reading is also important. So these are my humble summary. Otherwise, you have covered everything so nicely. We are so thankful to you. It's a great learning experience.
I
Thank you.
just want to share one patient with you. It's a newborn. I was called for echocardiography, child in an ICU, 27 days old. And I did echo. It was severe LV dysfunction, moderate MR, moderate TR, EF hardly 20%. I felt a pulse. Like you can feel when it is hypertensive pulse, you can feel. And when I do echo, I always check the gradient of all valves. So mitral gradient was coming 120. That means blood pressure at least 120
More
for
than
a is old child. So you can imagine the hypertension कहाँ तक आपको परेशान कर सकता है. We worked on his hypertension. It was renin was high and he received steroid many boluses and things. So just by giving the antihypertensive drug, EF become normal in next 48 hours. So this is the beauty of picking these things. So hypertension is something we should not miss. Whether it is newborn, whether it is toddler or whatever age, BP should be in your mind when you are dealing with the admitted patient and OPD obviously after 3 years of age. And if any cardiac or anything being done, he required admission in ICU, these kids should have an extra watch for the blood pressure point of view.
Muneesh, there are 3 questions in the chat box we should discuss. Please comment on the use of milrinone versus dobutamine in decompensated CHF and also in post-op.
Okay. Good question. One is decompensated. Decompensated means child is in shock. Shock means is not maintaining your blood pressure. Low dose of dobutamine and milrinone both are hypotensive drug, reducing your SVR, and you are not in a condition of further reducing your SVR. Already your BP is compromised. You need to maintain a mean blood pressure. So here you need a adrenaline or noradrenaline. You need to maintain your blood pressure. Then along with that, you can add milrinone. You can select. Milrinone is a good for the peripheral vasodilator. But in this condition, decompensation means you can't start with milrinone. You need to maintain your mean blood pressure is very important because your all organs dependent on that. If you don't maintain mean blood pressure, your kidney go, your liver will go. So maintain mean blood pressure, add touch of milrinone, and then depending on how patient lactate things are behaving, peripheral is behaving, you adjust the dose of these things. So this is a combination you need to add in your decompensate patient. So adrenaline with low dose of dobutamine or adrenaline or NORAD that you can choose depending on your heart rate and the things, but both almost act on the same receptor along with one vasodilator. That is milrinone is a good drug, but it is slightly costlier. If not available, then dobutamine by 5 or 7 I do go use, but both in high dose obviously not recommended, not work. So this combination you have to be in your mind when in a decompensated stage. And patient
not as the initial drug, but after you stabilize, after that you add these drugs.
Yeah.
Yes. And also in post-op is also the same thing.
Same thing.
Duration of therapy of digoxin and furosemide in CHF. This is another question.
what क्या?
Duration of therapy of digoxin and furosemide in CHF.
Okay, so duration of therapy. One is, as we discussed, what
Ah.
the lesion is, what the etiology is. If it is correctable lesion, better to correct and make the child free of the medication. Okay, but in condition like cardiomyopathy, dilated cardiomyopathy, digoxin role I do use in pediatric till there is ventricular dysfunction is there. The second drug is diuretic. Diuretic is to decongest the patient only. So there is no other role of Lasix. Okay, if your patient is dry, Lasix is not needed. If it is congested, you are seeing liver is enlarged, face is congested, JP is raised, you definitely need Lasix. So Lasix, there is nothing like duration. It depends on the volume status of the patients. So Lasix usually not a very long-term drug. It is if you advise the adequate fluid intake, you optimize the calories, you optimize everything, you just come out of the Lasix. So Lasix is just related to only fluid status. It has nothing more to do. It just may add more to the electrolyte imbalance. So many things it will add to. Digoxin, for the shunt lesions, there is no specific role in digoxin. But for the cardiomyopathy, ventricular dysfunction, we continue on the and only maintenance dose. Not in the, you give a loading dose of the digoxin. More important drug here are the aldactone. More important drug is ACE inhibitor or ERNI, not together. So these are the more important drug for the long-term follow-up of the cardiomyopathy patient. And patient when hemodynamically is stable, you add beta blocker. Beta blocker, you add carvedilol or inderol, propranolol, anyone you can choose. Carvedilol have many effects. One is control heart rate, it lusotropic effect, diastolic dysfunction it acts. So antioxidant it is. So carvedilol has more effect, but you can choose between the inderol or the carvedilol. So long-term follow-up are beta blocker, ACE inhibitor or ERNI, digoxin. These are the drugs for our long-term follow-up.
Other group of patients with the left to right shunts, so there are surgical patients. So don't wait for those patients too long with these medications. So we advise for those medications, please shift those patients to the surgeon and get them operated. So don't wait for these patients with the medications. You think that the hole will close and let them continue with these medications. So this is not the advice from us. So 3 to 6 months, the timing of interventions are very well given in the guidelines. So please follow that and shift those patients for operation. So which are the surgical patients, all lesions which are correctable and the obstructive lesions, please let them go for surgery. That is our advice, right, Muneesh?
Yes.
So please don't wait with these medications. Another question is there, indication of pacemaker implantation. Do we need it if complete heart block with no subjective symptoms?
Like there were class 1 indication and class 2 indication and class 3 indication, obviously when it is not indicated, heart rate. So complete heart block doesn't need pacemaker. Okay. It is the heart rate which decide the pacemaker. It is a symptom which decide the pacemaker. If patient is because of bradycardia symptomatic, you have to go for the pacemaker. There is no discussion about that. When patient is asymptomatic, then comes that which heart rate I have to advise for the pacemaker. For the newborn, congenital complete heart block, if heart rate is less than 50, 55, we have to go for the we do advise for the pacemaker. If there is escape rhythm, it is white QRS. If there is long QTC there, if there is ventricular dysfunction, you need to go for the early pacemaker implantation. When heart rate is more than 60, usually we buy time. Sometimes even at 60, patient misbehave badly. There is acidosis, not maintaining cardiac output, newborn especially, then obviously you have to go for the. So one is heart rate, other is your post-op patients, like patient underwent surgery, cardiac surgery, and post-surgery he developed heart block. In that condition, we wait for around week or 10 days because we expect that edema will subside and heart rate may improve. If heart block persists, if it is below 70, you advise for the pacemaker. It doesn't, if it is more than 14 days, it doesn't come back. So we should be, one is, what is the cause? It is congenital or acquired. Congenital, these are the things when we diagnose in fetal echo, we advise on this. And when there is heart block in fetal echocardiography, in 80% of the time, it is the maternal SLE which is the culprit. So diagnosing the actually majority of time, I know fetal heart block, and then we diagnose the mother antibody level. So it is always work in that way. Ideally, we should know beforehand. Any history of miscarriage should not be ignored, and the mother should be investigated for the antibody. That should be the rule. But that should be rule, actually. There is nothing if and buts. And because prevention is important, you start electively then on SCQ. You follow them closely. You may need IVIG. You need to deal them very differently and smartly when the mother and fetus things are happening.
I think you answered his next question also, Bartley. Do you have any anti-Q positive patient leading to complete heart block? It's related to myocarditis or myositis as per available information. It's found on ANA profile testing that it's anti-Q positive. So that you have answered that fetal profile, you have to be very careful
Hence, I
about.
want to share one mother. I'm following her. She is now 26 weeks. Okay. She came to, her mother was having Sjogren syndrome.